Hello everyone and welcome back to my channel. So today's topic is adenocarcinoma of the stomach. Important topic hai, so not that extensive. We'll just cover it in this video. So let's get started with this topic. It is the most common malignancy of the stomach, comprising more than 90% of all gastric carcinomas. Now there are two types basically, intestinal and diffuse type. So I'll just first take you through this basic classification. So the classification of stomach adenocarcinoma is: number one, according to histology, we classify it based on this Lawrence classification, under which we have these two types, intestinal and diffuse. And according to the growth of the tumor, we have this ulcerative type, fungative type, or infiltrative type. Okay. Now this is the infiltrative type, which is very famous, which is called the Inicet plastica or leather bottle disease or diffuse type of carcinoma or Brindle's disease. So all these are kind of names of the same tumor, which is the infiltrative type. Now under Lawrence classification we had the diffuse type, and under the classification according to the growth of the tumor we had the infiltrative type. This diffuse type and the infiltrative type both are same. Okay, both are same. So infiltrative type is having this diffuse type of histology. Another important point is that what do you mean by this leather bottle appearance? Basically there is involvement of the whole stomach with rigid and thickened wall caused by diffuse infiltration of the whole stomach by tumor cells and extensive fibrosis. So basically the entire of the thickness of the wall is getting involved by carcinoma, by these tumor cells, and therefore the wall is getting thickened and rigid, and that's why it's called as leather bottle carcinoma. And it has a signet ring cell morphology in the histology. So very important, these are very important MCQ points. And coming to gastric antrum, the lesser curvature is more involved compared to greater curvature. Now there are other conditions also where you get Linitis aplastica appearance, that is when there is metastasis to the stomach. For example, in case of breast carcinoma or lung carcinoma, even in that case you do get this Linitis plastica. Now we'll talk about these individual points in details. So here I mentioned that there are two types, right? Intestinal and diffuse. So what is basically happening is that in case of intestinal type the tumor is bulky. Okay, but in case of diffuse type you will see that this tumor is not a bulky growth. It is such that it is infiltrating inside the the wall, and that will thicken the gastric wall. So this is the basic gross difference. Okay, and now coming to the histology, what is the major difference in the histology? Intestinal type mein you will get glands or glandular structures, and the diffuse type you're going to get signet ring cells. So this is the histological difference and this is the gross difference. Now what is the mechanism? So in the intestinal type, you have loss of function of the APC and gain of function of beta catenin. I have already explained this in one of my videos that whenever there is loss of function of the APC gene, you do have a gain of function of the beta catenin protein, and it is because APC gene usually down regulates the beta catenin. So whenever there is a loss of function of APC gene, the beta catenin will have its gain of function. Okay, and because of all this, there is going to be an increased signaling via this WNT pathway. This is exactly the what was happening even in the colonic carcinoma in the APC WNT signaling pathway also. So this is basically one of the mechanisms. There are other mechanisms also which is given here. So as you can see here that in the intestinal type you have this WNT signaling pathway जहाँ पे mutations हो रहा है APC gene का, which causes gain of function of the beta catenin, and there is also some kind of loss of mutation happening in TGF beta signaling pathway. Regulation of the apoptosis by BAX is also defective here, and the cell cycle control is also defective. Okay, FAP patients with germline APC mutations have increased risk of intestinal type gastric cancer. This is a very important MCQ point. जहाँ पे मैंने discuss किया था regarding the FAP and all, that is a very important chapter. A lot of MCQs are asked from there, and you must also remember this point from this particular topic, that FAP may that there is an increased risk of so many different other cancers in FAP, and in that condition also the type of gastric cancer which is a kind of having a risk, that is intestinal type of gastric carcinoma and not the diffuse type, क्योंकि यहाँ पर APC mutations हो रहा है, राइट जहाँ पे APC mutations होगा that is ultimately giving rise to intestinal type of gastric carcinoma, because the mechanism of diffuse carcinoma is different. In the diffuse carcinoma you will have a loss of function of the CDH1 gene. ठीक है, that mechanism is different. As you can see that basically the CDH1 gene is affected. This is a tumor suppressor gene. So when there is a loss of function of this or hypermethylation of this, now what is the meaning of hypermethylation? It basically means silencing. So when this gene is now having its loss of function, there is loss of E-cadherin, because this was ultimately coding for E-cadherin, and now there is loss of E-cadherin, which will kind of cause each of these cells not to stick to each other, and now these cells will be discohesive. They will be separated from each other, and that is why it is called as loss of E-cadherin. And this type of carcinoma will have a signet ring cells. Okay, so I hope that you are able to correlate. Now another point is that some inflammatory genes such as the interleukin 1 beta and interleukin 1 receptor associated with an elevated risk of gastric cancer in those who have H. pylori gastritis. So these are the basic two types. I have discussed the difference in pathogenesis in the gross and in the histology as well. So these are basically the three important differences that you must know between these two important classification of stomach carcinoma. Now if I just show you this image, you can see that this is basically the adenocarcinoma. You can see there's an elevated mass with heaped up borders and central ulceration, right? So you have an ulceration in the middle and you have this heaped up border. Okay, so this is basically your adenocarcinoma of the intestinal type, and this is the one which is the diffuse type, because you can see that there is no kind of specific mass over here. It's basically that the gastric wall is completely thickened and rugal folds are lost. Here you have this rugal folds, which means this is the normal part, and here it is lost, partially it is lost. So there is no dominant mass over here, but then the wall is so very thickened, and this is called as linitis plastica. So this is the gross image, and if I take you through these particular points, I've already mentioned all these points in that particular chart. So what happens is that in a case of diffuse carcinoma or infiltrative carcinoma, the neoplastic cells contain atypical mucin vacuoles. These cancers permeate the gastric wall as small clusters and individual discohesive cells due to the absence of E-cadherin. The cells do not form glands, but they instead have large mucin vacuoles that expand the cytoplasm and push the nucleus to the periphery, causing a signet ring cell morphology. And now a release of extracellular mucin in either type of gastric cancer can result in formation of large mucin lakes. Okay, so in case of linitis plastica, you have this desmoplastic reaction, which is so strong that basically the entire wall is getting involved. Now intestinal type cancer predominates in high risk areas and develop from precursor lesions including flat dysplasia and adenoma. Okay, so the depth of invasion and the extent of nodal distant metastasis remain the most powerful prognostic indicators in gastric carcinoma. So the depth of invasion and the extent of the nodes and the distant metastasis, these are basically the important prognostic factors. Coming to the other important points now, what is the link? If someone asks you what is the link between H. pylori and gastric carcinoma, decrease in the HCl, that is basically a risk factor for gastric carcinoma. Why? The growth of H. pylori will be promoted, and once there is H. pylori, that will convert the dietary nitrate into nitrite. So H. pylori is converting nitrate into nitrite, and this nitrite will further convert the dietary amines to N-nitroso compound, and you know that N-nitroso compound is a carcinogenic substance. It has a carcinogenic potential. Now the most important prognostic factor is this stage, and if I can just show you this signet ring cells ना, यहाँ पर आप देख सकते हो that these are basically the signet ring cells. As you can see that the nucleus is pushed to the periphery ना, यहाँ पर you can see that, see, this nucleus is pushed to the periphery. ठीक है, so this is basically the signet ring cells, just like the ring, you know. So this is a scattered and poorly cohesive neoplastic cell. You can see that they are not bound to each other, they are discohesive, they are poorly cohesive. Cohesive means attaching to one another, so this cohesive means they are apart from one another. They have a signet ring cell morphology. This large intracytoplasmic mucin vacuoles actually pushes the nucleus to the periphery. So this is the nucleus which is pushed to the periphery because of the accumulation of the intracytoplasmic mucin vacuoles. This is the diffuse type of the Laurent classification. And if you see here, you can see that these are the neoplastic glands. So this type is the intestinal Lorentz subtype. These are the intestinal gland. which is composed of epithelial cells, and these are neoplastic epithelial cells. Okay, so coming to this particular image, even here also you can see that this is basically the signet ring cell, right? These are the signet ring cells. As you can appreciate that the nucleus is pushed to the periphery, right? But here you can see that this is a neoplastic gland. So this is the intestinal type and this one is the diffuse type. Okay, so this is all about the important topic, which is the gastric adenocarcinoma. And now I'm going to take up this topic, which is lymphoma. A very important question or a short note, that what is lymphoma? Lymphoma in the chapter of stomach would mean maltoma. Okay, now what is the most common type of lymphoma? This is extranodal marginal zone B cell lymphoma. Okay, extranodal marginal zone B cell lymphoma. This is basically what is we are going to read is the most common type here that's happening, and this is basically known as the maltoma. Okay, so just going through this, that although extranodal lymphomas can arise in virtually any tissue, they do so most commonly in the GI tract, particularly the stomach. That they can originate in the pre-existing malt, such as the Pear patches of the small intestine. Now, these kind of maltomas, they arise within tissues which normally are devoid of lymphoid tissue. Malt is not present in the normal stomach, but if you have H. pylori infection, then you can have this malt, and that is why H. pylori infection is kind of associated with this maltomas. Okay, so now I'll be talking to you regarding the pathogenesis. Very important. There are basically two mechanisms that's happening over here. Please pay good attention. Now, an important point to differentiate is that in the first mechanism, there is no role of H. pylori. Okay, why? Because of these translocations happening. Here, translocations are happening which is constitutively activating the NF kappa beta pathway. तो because यहाँ पे सिर्फ translocations हो रहा है and there is no correlation with the H. pylori, therefore even if you give H. pylori eradication therapy, this will not work because it is insensitive. On the other hand, the other mechanism that I will be talking about, in the other mechanism there is no translocation, and therefore this H. pylori is the one which will trigger the NF kappa B activation, and this kind of lymphoma will respond to H. pylori eradication. So this is the basic outline, and now I'm going to talk about each of these in detail. Coming to the first mechanism, there are some translocations happening. Which are the translocations? Number one, T1118, number two, T114 and T1418. Very important points. Now यहाँ पे तीनों जगह में the proteins are different. As you can see that this translocation will bring together the API2 gene on chromosome 11 with the MLT1 gene on chromosome 18. So because of this translocation, now these two genes will come together to create a chimeric API2 MLT1 fusion protein. Okay, and this is the protein which will ultimately cause constitutive activation of the NF kappa B pathway. So what is the full form of MLT1? This is mutated in the malt lymphoma. This is the full form of MLT1 gene on chromosome number 18. And what is the full form of API2? It is apoptosis inhibitor 2 gene on chromosome 11. So once this translocation happen, these two will come together to form a chimeric protein, fusion protein, and that will ultimately cause this constitutive activation. Now similarly, if this translocation happen, then BCL10 will be increased, and if this translocation happen, MALT1 will be increased, all of which will ultimately cause constitutive activation of the NF kappa B transcription factor pathway, which will cause the B cell growth and survival, ultimately leading to extranodal marginal B cell lymphoma or maltoma. Now because this translocation is happening, there is no role of H. pylori, and it's insensitive to H. pylori clearance. There is no role of H. pylori. But on the other hand, in this particular mechanism, you have the H. pylori infection, and this is basically the one which is inducing the inflammation, and this will trigger the NF kappa beta activation through MALT1 and BCL10 pathway. Now please understand that these two translocations are not happening, but these proteins are coming into play over here. Okay, here only these proteins are coming into play, but there is no translocation. यहाँ पर translocation हो रहा था जिसके वजह से these expressions were increasing. Because of this translocation, these expressions was increasing, but here there is no translocation. Without the translocation, these expressions are increasing, which will ultimately cause the B cell growth, and therefore because of the H. pylori infection, because since this is kind of stimulated by the H. pylori infection, therefore this responds to the H. pylori eradication. So these are the two mechanisms of lymphoma. And now if we talk about the image, there is a dense lymphocytic infiltrate, as you can see in the lamina propria. The neoplastic lymphocytes infiltrate the gastric glands to create a diagnostic lymphoepithelial lesion. Important MCQ point. 40% tumors, they have plasmacytic differentiation. Maltomas express the B cell marker CD19 and CD20. They do not express CD5 or CD10 and are positive for CD43 in 25% of the cases, an unusual feature that can be diagnostically helpful. Just remember this point. This is basically what is important for you.